Now, while we were interviewing Jerry, Dr. McCabe was doing her LensX, and we're going to see an instant replay of her LensX and then go to her in the operating room. So Kathleen comes to us from Florida, and here's the patient, 72-year-old male, N3, normal axial length, less than a diopter of astigmatism, wants a restore +3. So let's take a look at the next slide. Here's the Varian planner, and with the planner, we can look that it shows a 20.5, and it shows that there's going to be two areas here of arcuates to help manage the astigmatism. So let's see the instant replay from the LensX.
You're going to feel a little bit of pressure here. As soon as I start to see that meniscus come up, we'll go ahead and we'll do section on. And we'll go ahead and bring that pressure back into the green area. When I push the button, it's going to go ahead and register now our docked image to the pre-docked image with Varian. So we can look at the screen on the left and see as it's showing us its registration. We can look at features of the cornea and the iris, like this iris nevus. Here's another nice nevus. Looks like those are just basically moving in and out. That's a great registration, so we're going to confirm that. We'll confirm it again. Automatically, all of our parameters have moved to where we want them to be. I am going to nudge some of these just a little bit. So if we click here on corneal incision position, it's very, very easy for me to decide, no, that's not exactly where I want it. Move it just slightly away from that scar, maybe a degree or two, make getting into the incision a little bit more reliable. We're going to scan, and this will let us know, once we see everything on the right, what's going on. So it also wants us to move our arcuate incisions. We'll just make sure those are centered the way we want them to be. I like to look at the margin of the pupil when I'm doing that to make sure that looks very even. And now we'll scan. The first thing we see is a ultrasound image of the capsule. You can see that it's nicely flat dock there. Everything looks good. Our parameters are on either side of the capsule at every point. I like where we are in the center of this. I always move my posterior gate for the nuclear fragmentation to about 500 microns. I find that that facilitates cortical removal. And except that, we'll look at the corneal thickness in just a moment. So this is our geometry for the primary incision. And now we're going to look at the arcuate. And here are the arcuate incisions. They all look great. We'll verify and accept. And here we go. Very quick treatment, very comfortable for the patient. What you may or may not have noticed is that capsulorhexis, which for me is a 5.0 millimeter capsulorhexis size, I then make my fragmentation pattern about 4.0 millimeter less. It does have those chop extensions to either side, and those I think hopefully we'll see that allow a little bit of tracking of the gas bubble, and that may have happened here. Don't move anything, you're doing terrific. We're almost done. All right, and treatment's complete.
Kathleen, thank you. You're on our screen. Beautiful demonstration of LensX. Nice explanation. You did a great job.
All right.
Welcome.
Well, thank you, and it's great to be here. And now we're in the operating room, ready to just get started with this cataract removal. And so we're going to go ahead and get started here. So we've already registered our pre-docked or our patient reference unit image to our OR image with a DMM. And right now I'm using a little cannula that I helped design with a little tapered end to it. I like to put a little bit of lidocaine and phenylephrine in the anterior chamber. That's really made a big difference for me too with IFIS cases. And then of course when I put in my viscoelastic, I'm sure that the cannula tip is over the floating and often free-floating capsule. Nice, easy opening to this primary incision. And I kind of evaluate that gutter.
So nice to see incisions open with a spatula instead of a blade.
Yeah, oh yeah. And that little taper on that spatula makes that very easy to do. I look at the gutter. I like to keep my fragmentation pattern slightly smaller than the capsulorhexis so that I can look at the gutter. And as long as I can see it 360 degrees, which is about 99% of the time, I can just grab that. One thing I'm careful to do is take that little plug of Cortex out of the incision before I start hydrating, because that will not allow for egress of fluid while I'm doing my hydrodissection. And I hydrodissect just like I would for any other case. I do like the Chang hydrodissection cannula because I can kind of get into the lens and rotate it, just make sure it's free. And with the Centurion balance tip and active fluidics, I know I'm going to have a nice stable chamber. I like to use a chopping technique. It's what I always did anyway with the Infinity. I haven't changed any of that or any of my technique at all, really, in going to femtosecond laser. And these little cubes are sized in such a way that it's very easy to just sort of aspirate them. So I've aspirated that central portion. If you look, this actually divided all the way out to the periphery from the gas bubbles of the fragmentation pattern with those chop extensions. So it's one of the reasons I really like putting those chop extensions on. They seemed at first to me like they weren't going to do very much, but they allow for fragmentation in quadrants of that nuclear rim. So the part that's not fragmented outside of my fragmentation pattern is already chopped into a quadrant, or like in this case, a heminucleus. And you can see I'm using...
So interesting, it's graded as a N3, and yet with the lens X fragmentation balanced tip, this makes this emulsification quite straightforward.
Yeah, it's really not much emulsification, it's more aspiration. A little bit of chopping there, not much at all. And again, nice, steady, stable chamber, so I can go ahead and get a lot of my epinucleus out very efficiently. And that's that.
Beautiful rexus. In that side view, we could see the perfect rexus. It looks like a beautiful circle.
Yeah, and this is actually, as you may recall from the femtosecond portion, it's centered on the pre-op pupil. So it doesn't look like it's centered in the limbus because it's not. I'll get a little bit of that bubble out. And I like this polymer tip a lot too. It allows me to go around, do my cortical cleaning just the way I would normally do it. I'm not worried that I'm going to encounter the capsular bag and do anything with a jagged edge or something unexpected is going to happen. And if I do grab onto the capsule, I feel very confident that it's going to be gentle and not really do any harm. And you can see this is just what I would normally do. There's nothing tricky about getting the cortex out here. It's also great for polishing.
If you want to try balance or try the polymer tip, it comes as straight, curved, and bent. There's 3 choices. And you can also do bimanual 23 gauge with a polymer tip.
Yeah,
so you have a lot of choices. This
is the curved tip, which allows me to get most of the way around. It's also good for aura. If you have a lot of lens epithelial cells in the on the capsule, it can mistake that for the pupil, so we don't like to do that. And that's nice and clean. I also power wash my posterior capsule. That's what I call it anyway. And of course, I'm kind of holding on to the cannula because I don't want to create a little missile in the eye here. But this way, nothing is in the way when I'm doing my aura measurement as well. And when I fill the capsular bag and the anterior chamber with viscoelastic, I do fill it a little bit more firmly than I would otherwise when I know that I'm doing an aura measurement, so that I have the proper pressure. And a little bit on the higher side, I'm going to burp a little bit out of that.
We can see your arcs very nicely there from that femto.
Yep. Yeah, that's one of the things I love about the femtosecond laser, actually, is those arcs always look so beautiful, exactly where we want them to be. Still, now it's a little bit low, so I'm going to fiddle here for just a second. Oh, okay. So what we're going to do now is actually turn our attention to aura here in a second. Now that's perfect. I'm making it perfect for all of you there. All right. So at this point, it's really such an advantage to have this Verify Plus, where I can actually look at the centration in my ocular. But what I like to do first is get centered on the screen. I look at that wavefront fringe image on the upper right and just make sure that looks good. And we're going to go ahead and squirt the cornea because I think I see, yep, you can see there's just a little bit of viscoelastic, might have been there. Looking pretty good, but we're going to make sure we kind of waited a little bit so we had some viscoelastic on the surface. And we want to make sure that fringe image looks good. Then if we look at the right hand lower square with those 4 dots, those are the LED images from the focus camera. And I like to see that those are nice and crisp, and we're going to get this centered well. There we go. And at this point, I can do my fine centration by looking into the ocular itself. Now I'm going to turn the light off here, make it easier for the patient to see that red light. Can you see the red light, Mike? Mm-hmm. All right, look right at it and go ahead and capture. Oh, don't move, you're doing fine. I'm going to move our focus up just slightly there. All right, let's see what we got there. So we had chosen a 20.5. You can see that that is the closest to plano. Aura is agreeing with our choice, and we're going to go ahead and we're going to just double check that. So, yep, and I'll need my reticle. Thanks. And same thing, look right at that red light for me. Looks good, capture. Oh, wait one moment. Oh, I guess it liked it. Yeah. Thanks, Laura. Yeah, we'll do that again. We just were irrigating at the same time. So we'll do it one more time here. And right at that red light. Perfect. And capture. Excellent. And once again, it's confirming. Now look at that consistency. That really looks great. We're within a half a diopter in our spherical equivalent. It's all looking fine. I'm kind of loving that. Our axis and our sill are a little bit different on the two, but spherical equivalent looks perfect. And 20.5 is what we had decided earlier. 20.5 is closest to plano. We're going to go with that. So it's really reassuring to be able to look at that and say, yep, we had a good plan, and Aura is confirming all of that. We're good. Now you can actually go to take measurement, and one thing we can consider doing, because that second image there had a little bit of residual cylinder close to the axis of our LRIs, is opening up those LRIs. This patient actually has a little bit of corneal scarring as well, so that might come into my consideration of whether or not I really want to do that at this moment or just see how he heals. And I think what I'm going to do is we'll go ahead and we'll just open that a slight bit here on the table. I like to use my little tapered cannula to do that. It just fits in there nicely. Sometimes I can see a nice effect right away. We're not going to capture that again, but we'll look at the live image and kind of see if there's a difference. These are pretty small. These are 22-degree arcs, so we may not see a big effect by opening them on the table, but sometimes I do. So, and you can go to just power calculation there. Aphakic, top left. Yep. And we'll just see what we get. Now, to do this, of course, you got to have the patient.
Some people open up the arcs in the office after surgery. Some people open them up on the table. It's a surgeon's choice.
Yeah, and you can see that's drifting down, and when we're really focused there, getting some that were down closer to a half a diopter of sill. Again, with this patient, a little bit of peripheral corneal scarring. I'm going to kind of wait and see, and we'll see what happens postoperatively with that healing. They can actually be opened again, even in the, I've done that a couple of times with a little bit, diminishing effect each time, but a little bit of effect there. So we're ready to go. We have our lens.
So we can see, again, we're going to use auto-cert. We have initial velocity, pause, final velocity. It allows this second hand to stabilize the eye.
Yep, nice and centered still. Such a controlled way of introducing the IOL into the eye. Looks great. And I'm just going to go ahead and tuck these haptics and make sure everything's nice and free. And
I like to use auto-cert on 100% of my patients. I'm used to that second hand stabilizing the eye, the nice consistent delivery. You can set the speed It's very nice. Just be sure the fold is correct in the cartridge. That's the
If you wanna
key
put me back
with
on.
AutoCert. Make sure the trailing haptic is on the optic.
Yep.
Don't have the trailing haptic trapped between the plunger and the cartridge. Just always check that before you step on the foot pedal.
Sounds like good advice.
Kathleen, it's a beautiful demonstration of surgery.
Now,
I just think that you showed us the nice LensX procedure. You've shown us the polymer, the AutoCert, Centration here. You've shown us the Verify Plus.
We're going to go ahead and just look at the
very nice.
different centration options with Varion, and then I think we'll be all done here. So I'll take that. So right now, that's pre-op pupil. So that is the center of the capsular rhexis as well. And in my experience, I've seen that the pre-op pupil oftentimes overlaps with the two Purkinje images, which was kind of my old way of doing it. And so I like that. It tends to be consistent with what I've seen work in the past. And so that's where we have it set right now. But in just a second, we'll go ahead and we'll look at what happens if we center on the limbus. And look straight ahead for me still there, Mike. So that's pre-op pupil still. And can we get limbus? So this is limbus. So you can see that did shift. And as we would expect, it shifted slightly temporally. And then if we want to do centration on the visual axis, we can do that as well. And we'll see that in just a moment here. So there's visual axis, pretty close to pre-op pupil, but we'll go back to pre-op pupil and confirm that's right in the middle of that central ring. That looks good to me. Perfect.
Beautiful demonstration. Thank you very much, Kathleen. I really appreciate it.
All right, thank you.
One-day post-op restore, Malcon. Main incision here healing well. Two perfect arcuate incisions here. Anterior chamber, very little inflammation. I'd say trace to 1+ cell. And we have a restore lens here, perfectly centered. Pupil, of course, still with a little residual dilation. Blink for me, sir. As that pupil comes down, the vision should just continue to improve. Uncorrected vision pre-op was 20/60. Today, even with the dilation and some light surface irritation, he's already down to 20/40. Should just continue to improve.